Hello, everyone. Okay, we're going to get started. Welcome to the Rural Emergency Hospital Education and Fireside Chat. We are so excited to have with us today 3 CEOs who we will be chatting with a bit later in our presentation. We do have a packed agenda, and so we're going to start with giving you a brief overview. If you've joined us before, you may have seen some of this information, but if you are not familiar with the REH designation, we're going to go over at a high level the policies and requirements of being an REH. We're going to talk a little bit about the Rural Health Redesign Center and the technical assistance that we have available to you all. And again, we're going to have a fireside chat. Janice Walters will be leading that discussion with Aaron Herbal, Bob Moore, and David Mance. And then we will close out our session today with some resources and next steps. As always, we want to note that the work of the Rural Emergency Hospital Technical Assistance Center is funded by Health Resources and Services Administration, also known as HRSA, of the U.S. Department of Health and Human Services. Again, we have with us today Janice Walters, and she is our Executive Director here at the Rural Health Redesign Center. We also have Anna. Anna is the Program Director for the Rural Emergency Hospital Technical Assistance Center here at the Rural Health Redesign Center. And then my name is Angie Slemock, and I am a Project Manager also here at the RHRC supporting the Rural Emergency Hospital Technical Assistance Center. And I will be your moderator today. As a brief introduction, Janice is a highly rated rural health expert with 20 plus years of leadership and healthcare finance experience. She works closely with rural health executives, state and federal programs, and other community partners to ensure rural communities across the U.S. have access to quality health care. Janice has overseen the implementation of Rural Health Redesign Center initiatives, including the Pennsylvania Rural Health Model, as well as the Technical Assistance Centers for the Rural Emergency Hospital and Rural Northern Border Region Healthcare Support Programs. Anna is a nurse executive and previous Critical Access Hospital CEO. She is a transformational leader and enjoys working with rural hospital leaders to innovatively maximize their impact to the rural communities they serve. Anna joined the Rural Health Redesign Center in November of 2022. And in addition to her role as a senior leader, she is the program director for the Rural Emergency Hospital Technical Assistance Center. Before we get started, I wanted to go over a few housekeeping items to just keep in mind. You may notice that all of you are on mute. This is just to avoid any background noise. When possible, we ask that you use your webinar link to log in rather than using the call-in option. This will ensure that you have the best audio quality experience. And we do encourage you to ask questions, so please feel free to use the Q&A feature. You'll find that at either the top or the bottom of your screen, depending on your layout. And if you need closed captioning, that is also available. To access that, you'll go up to the More option at the top of the screen with the 3 dots, and then you'll select Language and Speech, and then choose the transcription option for closed captioning. The slides and recording for this webinar will be available on our website, rhrco.org, within 1 week after the event. And if you have follow-up questions, you can reach out to us at rehsupport@rhrco.org. Okay, just wanting to go over our objectives today, which are to provide you a high-level overview of the REH, review REH policy and requirements. We also hope to have you learn a little more about us and the technical assistance we offer to the rural emergency hospitals. And again, most of the portion of today will be spent in the fireside chat with our CEOs. So with that, I am going to turn it over to Anna, who is going to give us the brief overview of the REH and then talk about the technical assistance that we have available here at the REH TAC. Anna?
Thank you, Angie. So I'm glad to be here with you today. I'm excited to be able to share the information about the Rural Emergency Hospital Technical Assistance Center. But first, I want to share who we are. Our team at the Rural Health Redesign Center consists of healthcare leaders and subject matter experts. Our mission is to protect and promote access to high-quality healthcare in rural communities with a vision to really help rural communities thrive. I count it an honor and a privilege to speak with hospital leaders each day and provide education and guidance on the REH designation. My role as the program director at the REH Technical Assistance Center is to work with hospital leaders as they complete a thorough investigation into the REH designation to see if it's right for their facility and for their community. So I want to take you through a quick overview. We want to spend as much time with the hospital CEOs as we can, so I will go through these slides fairly quickly. But the Rural Emergency Hospital designation was established by the Centers for Medicare and Medicaid as a new provider type on December 27, 2020, and became effective on January 1st, 2023. The REH provider type was created to give rural communities an option to operate hospitals as an emergency and outpatient care facility. The intent of the REH is to reduce the number of hospital closures and improve equitable access to care by offering innovative payment for emergency and outpatient services in rural communities. The REH designation is the first new rural provider type since the Critical Access Hospital was established in 1997. So to qualify for REH status, the hospital must meet eligibility criteria, which includes being licensed as a critical access hospital or a rural PPS hospital with fewer than 50 beds, be enrolled as a Medicare provider. They must meet staffing requirements as per the conditions of participation. They will need to maintain an annual average length of stay of less than 24 hours, and they must meet the requirements for state licensure. They also have to have an established transfer agreement with a level 1 or a level 2 trauma center. And they have to have an action plan, which includes information on the services they'll continue, discontinue, maintain, modify, or potentially add. And that action plan, the transfer agreement, and a self-attestation form confirming compliance with the conditions of participation for the REH must all accompany the application. So there are services that the REH must provide, and that includes 24/7 emergency and observation care. They must provide diagnostic lab and radiological services to meet the needs of the patient population they'll serve. A pharmacy drug storage area and discharge planning, which is overseen by a qualified professional, is also required. REHs can also offer additional outpatient services, including such things as transport services, behavioral health, outpatient surgeries, and telehealth, just to name a few. This is not an exhaustive list, but as you can see, the REH has great potential to continue to meet community need on an outpatient basis through multiple potential service lines. The payment summary, I wanted to give you a quick overview of what that looks like. So we'll look at the losses and the gains. So let's first look at the losses. All inpatient services will need to be discontinued, including swing bed services. The REH is not eligible at this time to participate in the 340B program. And if the converting hospital is a critical access hospital, they'll lose their cost-based reimbursement. But if we look at the other side of the slide, which shows us the gains, we know that the REH will receive OPPS plus 5% payment for Medicare fee-for-service, and they will also receive a little over $3.3 million each year, broken down into monthly facility payments. It is important to note there are no payment changes to the rural health clinics, and that has been a question that has come up in the past for us. So hospitals applying for REH designation are required to submit an application, and that includes an action plan, at least one transfer agreement, as I said earlier, with a level 1 or a level 2 trauma center, and an attestation form for meeting the REH conditions of participation. The application process, the time varies. The shortest we have seen is about 30 days, and somewhere the norm is around 90 to 120 days. So as we meet with hospitals who reach out to us for additional information, we take them through a process of education. We also provide tools such as marketing and communication tools that can be used for educating their stakeholders, their community, and their staff on a potential REH conversion. Our team provides a very thorough financial assessment that demonstrates the impact of what an REH conversion would look like in comparison to the current hospital designation. We continue to provide technical assistance based on each hospital's individual needs. And again, there is no cost to the hospital for these services. So when a hospital reaches out to us, we have an initial introductory call to learn more about the hospital, their individual needs, and to determine that they meet the eligibility requirements. If the hospital is interested in learning more, then we take them through a more thorough process, which includes financial modeling and education on all things REH. At the point the hospital makes a decision to apply, then we'll assist that hospital as well with the action planning and walk with them through that application process. What's exciting to all of us here at the RHRC is that this partnership can continue to go on in the post-conversion phase as well. Once the hospital is approved as an REH, we invite them to participate in a monthly REH peer network for shared learning and networking with other REH CEOs across the country. So that I know is a very quick overview, but as I said, we want to make sure we have time to hear from our hospital CEOs. So I'm going to hand it back to Angie. Thank you, Angie.
Thank you, Anna. So we are very excited to have our three CEOs with us today, and I'd like to briefly introduce each of them to you. Bob Moore. Bob has more than 40 years of experience as a CEO in hospitals from small rural to large teaching hospitals in Illinois, Missouri, Pennsylvania, Florida, Alabama, and Arkansas. Recently, he converted Helena Regional Medical Center, a 48-bed financially challenged rural Arkansas hospital, from acute care to rural emergency hospital status, enabling the hospital to stay open and serve the county of 18,000. Currently, he serves as interim CEO for Quorum Healthcare of Brentwood, Tennessee, following retirement in 2019 and again in 2021. Bob is president of a consulting company working with mainly rural hospitals to identify ways to financially survive and thrive in today's turbulent healthcare space. And next, we have David Mance. David has served for over 40 years in a broad range of clinical and leadership positions to help provide excellent patient experiences in healthcare. David's first job in healthcare was in the supply department stocking medical supplies. David's clinical background in respiratory care, mostly in pediatric critical care, and he was previously the director of respiratory care and pediatric air and ground transport team at Le Bon Air Children's Hospital in Memphis, Tennessee. David's leadership roles over the past 20 years were in both large and small facilities, from department director to CEO. David has been a frequent public speaker on a state and national level with topics addressing leadership, performance improvement, and preparing for future changes in healthcare. David and his wife, Jamie, have 4 daughters and 5 grandchildren. They spend their spare time enjoying cooking, gardening, hunting, fishing, and especially time with family. And then we have Aaron Herbel. Aaron is the Chief Executive of Mercy Hospital, Inc. in Moundridge, Kansas, serving as administrator since April of 2017 and as CFO since February of 2019. He leads the facility in meeting the healthcare needs of the community by exempling compassionate leadership. He piloted the organization through the COVID-19 pandemic and several years of financial uncertainty. A chief accomplishment has been the successful transition to the new rural emergency hospital model in early 2024 to ensure the financial sustainability of the organization. In his spare time, Aaron enjoys reading, writing, traveling, and spending time with his wife and 4 children. So you can see why we are very excited to have these gentlemen join us. So welcome to Bob, Aaron, and David. And leading us through this discussion is our Executive Director, Janice Walters. Janice, I will hand it over to you.
Thank you, Angie, and certainly very exciting. And to set the mood for the fireside chat, we're sharing with you a wonderful beach fire. So hopefully that will help you all relax and just enjoy the conversation that we're going to have with our CEOs today. So just to frame the conversation today, 2 of our CEOs, Bob and Aaron, actually have made the transition to the Rural Emergency Hospital. But David, as he leads his organization, they've not made that decision. And so we thought it would be good to just have a conversation with the three of these individuals to identify what helped Bob and Aaron decide to make the transition. And David, what is causing him pause, and just really understanding the thought process brought forth by all of or by these three CEOs. So my first question today goes to Bob and Aaron, and it really is about the transition. And how was the transition to the REH designation? How has it affected your facility? And has it been beneficial based on what you've seen so far? So if you can remind everyone again when you transitioned, and how has it affected your community, and do you see it as being beneficial? So Bob, if you want to go first.
I hope that the fire that we're looking at with the water that can't quite get to it is not symbolic of what we face these days. Some days it feels like there's a fire. The REH designation for Helena Regional was really a no-brainer because the hospital was facing closure if we did not get the financials turned around. It was a hospital that should have been a critical access hospital many years ago. It wasn't. It was also unique in that we were licensed for 135 beds. So when you use the under 50, you didn't qualify. So we had a lot of things on the front end. That was about a year ago right now that I started working on when I was there as the interim. And we converted, we applied in October. December 5th of 23, we received the designation. And it really allowed the hospital to stay open. And in January, I finished a sale of that hospital to a company out of Oxford, Mississippi that is operating several REHs around the country. And it's been a very good transition. ER visits are down slightly. And part of that is I think people feel they bypass if they think they have to be admitted. So that's one of the downsides. And, we're close to Memphis. We're not that far from Little Rock. So there are some other options, but financially, it's much better in the first 6 months. And I think it'll continue to only get better. And a little later, I'm sure we'll talk about some of the stats and you'll see what that transition has done financially.
Great. Thank you, Bob. Aaron, thoughts? How has it affected your facility? And has it been beneficial so far?
Yes, thank you, Janice. And initially, I would give an unequivocal yes, that it's been a positive transition for our organization. And I feel like the community has really responded positively to the change that we made. In my 7.5 years as the CEO here, the thing that I've heard the most from the community that they did not want to lose was the rural emergency, the emergency room. And so we knew as the board, as the medical staff going into this transition, that was one piece that was a non-negotiable. We absolutely would be able to continue providing that to our community. I would echo what Bob just said, that, we have seen a slight reduction in ER volume. I would attribute that the same way he did to patients, whether they're coming by EMS or private vehicle, that realize they know coming in that they're dealing with a serious medical condition. They're not going to be able to be admitted inpatient. So the patients are self-triaging and going somewhere where they know they can be admitted. But I would say our ER volumes have actually rebounded from the initial. So we converted to a rural emergency hospital effective January 1st of 2024. And so started the paperwork process in late September through the licensure and everything. But we saw kind of a dip in February and March, and then that's recovered. April and May were much more normal in terms of ER volumes from what we expected to see. So it's resulted in about $150,000 a month positive cash flow for our organization. So, giving up the acute inpatients, giving up swing beds, and then in exchange, that REH facility payment, that's about what it's meant for our facility, which you annualize that, and you're talking about a significant amount of money that is able to be here in the community to help ensure that there's quality medical staff available.
That's great. So David, you're in a little different boat. Bob and Aaron both went through the process and chose to convert. However, you've not made that decision yet. So can you tell us why? What is it that has made you pause a little bit, even though that you went through the process? What's causing you to pause on making the transition?
Sure, Janice. Thanks for having us today. I'm happy to be here. We have been studying this for a while. You know, you start hearing about it a few years ago when it was proposed in Congress, and they were referred to, initially I saw it referred to replacing the obsolete critical access designation, which I don't agree with. I think there's still a lot viable about the critical access model. We found ourselves in a fairly stable financial situation. We're not setting any records by any means, but we are in kind of a leveled off and stable position. So we're not looking for the REH for survival. And I think that's one key point. We had an excellent crew with the Rural Health Redesign Center. Kathleen and Dan were our point people. We were fortunate enough to get involved, and we had an in-depth assessment financially and otherwise of the impact the REH would have. And it basically came out to a financially neutral outcome for changing. So the community, we were trying to be very transparent. We have a county government, and we're a county hospital currently changing to a 501c3 organization, not for profit, but we report to the quorum court. For those that don't know what that is, it's like a city council for the county in Arkansas. And so I report to them monthly. I included them in these decisions, the information along the way, try to keep everybody very up to date and informed. And there were a lot of people that were concerned about, you know, not being able to have mom in the hospital out here for 2 or 3 days. And the swing bed is probably one of the top factors. Not having swing bed, not having 340B, those are huge issues. But when it came down to it, we have a lot of things going on, and the board, as well as I, agree that it's just something we're going to kind of watch and see.
So you had a little luxury of time, from what I'm hearing you say, that you didn't necessarily have a burning platform, and so you feel like you have the ability to kind of watch and see. And certainly we know some legislative changes have been introduced at this point that might make this a little bit more palatable for folks like yourself. So going back to Bob, you know, one of the things that as we work with hospitals, you know, to identify a path forward, you know, the REH, the fixed facility payment, is a way to get revenue into the organization a little bit differently, but certainly could also include operational changes. So what type of operational changes did you make there at the REH, at the facility to prepare it to become an REH? And has that had any impact on your cost structure?
Yeah, there were quite a few operational changes. Anybody that's familiar with Helena Regional, or now as it's called, Progressive Health of Helena, it's a one-story structure that you could get your 10,000 steps in just walking to the ER and back to the administrative suite. So we were able to consolidate all of the services that would be needed for the REH really at one end of the building. So ambulatory surgery recovery area was, a door was placed between the ER and the ambulatory surgery area, and that's the OBS unit. So connected to the nurse call that went into ER, telemetry into the ER, so that ER nurses, the ER physicians, and ancillary staff really had access to those OBS patients when they needed, when we had those patients staying there. That freed up a lot of space in the building that the new operators can then look at how do they refit that for other healthcare uses. You know, I think most of our communities need mental health services, and we don't offer them. So there's some space that's going to be made available. It consolidated, like I said, all the services. And by doing that, it did help on some operating costs. And our operating cost, again, comparing quarter to quarter, we're down about 24% from where they were in 24. Now, a lot of that's labor cost, because there was 13 fewer FTEs. But by doing that, it changed the bottom line to where, again, in the first few months, it was real close to a break even instead of a 7-digit loss.
Very cool. So kicking over to Aaron, certainly So Bob's talked about the operational changes that he made at his organization. And I would throw this out to Aaron to go first, and then Bob, if you would have anything to add to it. But what types of clinical changes did you make? So certainly, changing from getting rid of inpatient services, all of that. But were there other clinical changes that you made to your organization as well?
So one of the things that we did, we actually had already taken a look at this prior to the REH conversion, but we opened it after the conversion date on January 1st, was a walk-in clinic. And so we were able to redeploy some of our nursing staff that had been involved in inpatient care before to staff the walk-in clinic that's now available 5 days a week and on Saturday. And that's providing a level of care to the community that we didn't have access to before. So even when we had discussions with our community members about what's going to be changing at the hospital, we were able to tell them that, we're going to be offering more services and access to a level of care that you haven't had in the community previously. We did already do outpatient scopes like colonoscopies and EGDs. So that was an area that we really continue to emphasize. And we look at emphasizing our emergency room and making sure that we have adequate staffing in that, really preparing to handle probably a better volume, better able to handle the volume than what we were able to do before, where we were sharing staff back and forth between the inpatient unit and the ER. We maybe didn't have as much opportunity to save on clinical staff compared to some organizations because we're a very small facility. We're only about 27,000 square foot total. And typically we were at minimum staffing levels. So there wasn't a lot of flexibility there, but we were able to redeploy some staff and see some savings there. And certainly saw on supplies is one area that we've really seen some savings because we're not, utilizing some of the drugs and some of the medical supplies that we were using before taking care of inpatients and swing bed. So that is one area that we've seen some savings.
So when you got rid of your the inpatient unit, knowing that you were already doing some outpatient procedures, did you have your medical staff raise concerns in terms of suddenly not having that inpatient unit behind the outpatient surgeries? Did you have any issues there? And if so, how did you manage those?
Yeah, I would say there were definitely concerns when we initially approached our medical staff about the REH model. And this would have been summer of 2022. When we first started having serious conversations with our physicians and our mid-level providers about this, that was one of the first questions that they asked, and was a chief concern all the way through. But we really had the data to show that our patients on the outpatient surgery side have very, very low. In fact, I would say almost zero rates of needing to return for an inpatient stay after a colonoscopy. Our quality numbers were very good, and that gave us the confidence that we're also within 20 minutes of 2 other PPS hospitals that we have put transfer agreements in place with. So in addition to the level 1 trauma center, which is a requirement, as Anna talked about earlier, as an REH, we have to have that transfer agreement. But we have agreements with 2 other PPS hospitals. They offer OB services. They have ICUs. And so we know that we have local people. Their CEOs are both a friend of mine. And so we have these strong relationships with these other local hospitals where we can send patients from our emergency room when they do require those inpatient services. So that's been a big help to our medical staff, knowing that we have those relationships in place with physicians that they know and trust right here in our county.
Very good. Thank you. David, anything, or excuse me, Bob, anything you'd want to add to
Well, I think
augment what Aaron said?
Yeah, I think there's been very few clinical changes at Helena. And the reason I say that, in 2020, I said we were 135 licensed beds, but over the last 10 years, the highest average daily census was 14 over the last 10 years. So we'd already, since 2020, we had shut down OB, we shut down ICU, we got out of some swing bed services we had. And we really had an average daily census in that inpatient unit of true inpatients of about 0.8 and about 1.4 total. So moving the observation patients down to the ER, we also moved another nurse down there 24/7. So there's 3 nurses down there now. So from an access, it really improved. We weren't having to share staff. And I think it's helped on the throughput. The left without treatment, left without being seen have declined. And I think if anything, it probably improved the clinical care because surgery is already shut down as well.
Very good. Thank you. So David, if your facility would decide to convert, what would be the most significant change or challenge you would face with becoming an REH?
As far as a challenge, I think the community would have to get more information. I think it would really need to be a needed change. And so I think that would be one challenge. I think that the fact that we have 2 rural health clinics, we employ all of the physicians and nurse practitioners in our town. And so we have a very robust 340B program, and it's doing what it was designed to do. It's helping us to continue to be open and provide services. So I think not having the access to the 340B program, which honestly, I don't really understand that stipulation, but I think that would make a huge difference for us if we could continue that and potentially the swing bed portion. And Bob mentioned behavioral health services. We could lease our empty rooms to somebody else to run a program, but the way I understand the regulations is that we could not own that and operate it ourselves, which, I mean, our motto is we're the people you know, caring for the people you love. And so we really kind of pride ourselves on being local people that people know and take care of. So we kind of lose that if we leased out space to somebody else.
Mm-hmm. Thank you. So this question is to like all 3 of you. But you know, it's already been mentioned here, the involvement of the community, and the need for the community support in order for this transition to be effective. So, you know, Aaron and Bob, how have you engaged the community thus far? And even David, like, how have you engaged your community on this journey with you?
Aaron, you
Bob,
want
I
to
was
start?
gonna say, I'll point to Bob. I'll go Bob, David, Aaron, because that's what the order you are on my screen.
Well, I think, as I said to begin with, unfortunately, Helena Regional was facing, our company leased it, and our lease was up, or would have been up at the end of this year, and we would not have renewed the lease. So the city would have had the hospital back. So going back 3 or 4 years ago, conversations started to be held with the community that basically you've got to use this hospital, or you may not have it here. And there's a lot of chemical plants along the Mississippi Delta that are located in Helena and Arkansas and Phillips County. They have to have access to an ER because of exposures or potential things. So the community knew they needed to keep an ER, and they didn't like giving up OB and all the other things, but they realized that probably 90% of what they need is radiology, it's lab, it's PT, it's speech, it's ER, and they were able to keep all of that by converting. So they were very supportive. So I think we were in probably a little more unique situation and community than a lot of rural hospitals face.
David, thoughts? How have you engaged the community so far?
Yeah, I mentioned the Quorum Court, and I used that platform to speak to the Quorum Court and help them understand the designation. And as we were going through our assessment with you guys, kept them up to date. Those meetings are reported in the newspaper. We're a very small town, 4,300 people. So, you know, it's kind of word travels fast at the restaurant breakfast table. I think probably the best place to do advertising and promotions. So, you know, we've got board members and employees that eat breakfast with the group every day. And I think a lot of things get passed on that way. But I think it's very important, no matter which way it goes, that it's not a surprise to the community. I think that is my personal thought, that it just really needs to be a very open, transparent conversation and transaction.
Thank you. Aaron, your thoughts?
Well, I would just say yay and amen to what David just said about transparency and openness to the community. We are a small community also. We're only about 2,100 people here in the town. I mean, we serve a population of about 8,000 that's in the hospital service area, but once again, your local coffee shop, that's where the information is going on. And we really utilized, looking at the runway, if you will, to the REH conversion. We utilized our patient family engagement committee and the connections that those individuals had within our community. We were able to bring that group in and do more focused information and even data review about, okay, let's be realistic. Just like Bob said, our inpatient census was less than 1 patient a day for acute inpatient. A swing bed, we were at about 4 patients a day. But, that statistic spoke to our patient family engagement committee members, even those that were older, that, were the loudest voices that the hospital must keep acute inpatients here in town. I don't think many people realized how few patients there actually were here spending night in the hospital overnight. And so getting some of that data out into the community and helping them understand, what, ER volumes are going up. Outpatient surgeries have increased over the last couple of years. Outpatient therapy has just been very, very busy and increasingly so. And all of those services are staying, just like Bob said, really making the conversation about what the community is keeping rather than what the community is losing. And when we could use the statistic that only 8% of our patients are utilizing the hospital in an overnight inpatient status, whether that was acute or skilled, that spoke to them. And 92% of our patients aren't going to be affected at all. They're going to walk in the front door and they're going to access the hospital just like they always have. So that message and getting that message out, I think it's really important for any community to make sure that you don't broadside your employees, you don't broadside the medical staff, you don't broadside the board with any kind of information. And that openness and transparency at every level of the conversation goes a long ways towards helping people feel like they've really been included in this conversation. Mm-hmm. And they understand that the hospital's not making this decision because we're trying to be punitive or we're trying to, treat people unfairly, but we're really doing it because we want to ensure continuity of care and access to services.
Right. Great. So the next question, again, just throwing out to all of you, but I'm going to ask you to start, Aaron. So certainly, we, I think, all recognize that the statute as it stands today might not be ideal. That, there's potential ways to improve it. And we all know that the critical access hospital, language as of today is not where it started, that there's a journey. And hopefully changes will be made to this to make it a little bit more appealing. But like in 30 seconds, if each of you could just say, if you could make 1 or 2 changes to the statute, what would that be?
The number 1 change for us would be to allow those REH facilities to operate swing beds. I mean, that'd be the number 1 thing for us. Our community has really, I would say, mourned the loss of the skilled nursing beds in our community. We have lost over 100 skilled nursing beds. 3 other skilled facilities have closed in our county in the last year. And we were really hoping to be able to continue providing skilled nursing services. And when it came down to it, the regulatory understanding of the law doesn't allow for a hospital-based skilled nursing. It's only on the adult care home side. And so that was a big blow for our organization because we were really hoping to be able to offer those services. And, we haven't historically been a 340B program, but from what I understand, that's probably the second biggest thing. If we would qualify automatically like critical access does, we would probably take advantage of that program.
Right. Thank you. David, I think I know what you're going to say, but sure, go for it.
I already gave my cards away. The swing bed's important to us from the community standpoint. Ours, unfortunately, isn't a huge, robust number, but it is very important for so many people. We send a lot of patients to tertiary centers, and they think and feel that it's very important to be able to come home when they're well enough. And then they can do that to swing bed. They can be closer to family. And we're a smaller group. We can offer more caregiver to patient time, and they just have a great experience here, again, with people they know. And with 2 rural health clinics, our 340B program is very robust. So that would be a huge improvement if we could include that, like I said before. Thank you.
And Bob, from your perspective, while you're no longer there, what would you think changes should be?
Well, I agree on the 340B that both Aaron and David said, that should be allowed. I think another thing is it shouldn't be based on licensed beds. It should be based on average daily census to qualify. As I said, what What Helena had were too many licensed beds on the book, and we had to go through a lot of rigmarole to refile cost reports to get the beds under 50 to qualify. So I think looking at an average daily census, if you're a rural hospital and you qualify, instead of looking at licensed beds, one thing. And the second, I think the December 27, 2020 ought to be waived. Healthcare changed in 20 going forward, and it's never going back. And I think Congress needs to look at that date. And then I guess one final thing, there are so many OB deserts in this country, and it's getting worse. And David knows this in Arkansas. It's becoming very, very risky. I think OB, larger than just some labor and delivery services that you're allowed to have, ought to be a carve-out category, kind of like swing beds. So that's what I would do if I was making changes.
Yeah, thank you. So again, we were excited to see some legislative changes get introduced. So there are some bills out there, which is encouraging to see that some of what we talked about today, language has been put forth to hopefully modify the statute that might make it more appealing for some other hospitals to consider, but then also as you folks that have already converted, to enhance the care that you can provide there in the community. So again, throwing this out to the three of you, can you talk a little bit about how the Rural Health Redesign Center helped you on this journey? David, maybe we'll start in the middle and then we'll go to Aaron and then Bob.
Great. It was invaluable. Absolutely. We would have been shooting in the dark without their help. They gave us time. They did really thorough assessments, and they both, Kathleen and Dan, presented, and Anna presented to our board twice by video, helping them understand the facts and the implications and the outcomes of the assessment. So it was fantastic for us. I think all three of us, where Bob was and where Aaron are, the resources are slim, and so you don't have 4 people you could task this to work on it. So it was absolutely wonderful. I would highly recommend it. And I'm not paid to say that.
Aaron, thoughts?
Yes, I would say too, limited resources with our facility. All of our administrative and finance people are already wearing multiple hats and working overtime just to try to keep things going. So having, particularly early on, that financial assessment piece to dig into the cost report information, to be able to do modeling 5 years out. That was information that we could take to our CPA that does our cost report preparation, that we could take to our lender, our banks, and show them that what we were working on was going to work for our organization. I think having a third party work on that, it wasn't just something that we came up with this model and it looks like it's going to work. That was very helpful for us in our situation, to have an outside body that had looked at those numbers and had something substantive that we could work from. And then I would say the second most valuable piece for us was the review and just templates and kind of knowing where to head in. The REH model is so new. There's not a lot of peers that you can talk to. So I really appreciate RHRC pulling together the peer network, allowing us a platform that we can bounce questions off of each other and, kind of know. Now it's kind of transitioned for those of us who are rural emergency hospitals to survey preparation, as that first round of state surveys starts happening, in the next year probably. And, really going nuts and bolts about what needs to happen. The ongoing technical support is the third thing that we just really appreciate as invaluable to us, because we don't have any more administrative people now after we've converted than we had before we converted. And so anytime you're adding that extra workload, that's very helpful. And the RHRC people are tremendous in terms of what they understand about the regulation, even as new as it is. And that's very helpful for us.
Great, thank you, Aaron. Bob, anything you would add to that?
I'd echo everything was said. Very valuable. We were well on our way when we found out about the RHRC in September last year, but you helped to validate what we saw. The toolkit and the online resources are very, very valuable, and I know get used quite a bit, as Aaron said. So, any hospital out there that is thinking about it, make sure you contact the RHRC and get involved right away, whether it's with the cohort or the online resources, because you're getting some tax dollars coming back in a very valuable way through them.
Great, thank you. So final question, and then Angie, I'm not sure if we've got some questions that have come in through the QA or not, but my final question to all of you would be, what advice would you give a hospital who might be considering the conversion to the REH? What would be your words to them? So let's start with Bob.
Well, I'd say if you're a hospital CEO and you know your hospital is facing financial ruin or potential closure, don't sugarcoat it to your board and your medical staff and your community. Start talking about the real problems and look at what the alternatives are, because there's a lot of hospitals out there that are closed and those communities are dying around them as a result of that. And if you get the board and your providers involved, they're the ones in the community that probably have more clout and than we do as CEOs. So you don't hide it from them. Just tell them, lay it out what we're facing if we don't make some serious changes.
David?
Yeah, thanks. I think the transparency is hugely important that Bob brings up. We have a little money in the bank. So my statement is, we have a little money in the bank, so we have time to change. You know, we know that sooner or later, this model isn't going to work with our average daily census, which is very low, like Bob shared. And we're paying to take care of those 2 to 3 patients, the same as we'd be paying for 10. So the model is very fragile. I like to say, and I like the saying that wise men and women move slowly, but the dilemma is sometimes you have to be quite nimble and quick to change to survive. So I definitely would utilize the RHRC. And again, the communication I think is huge, but they were the right folks for us, and you guys know what you're doing, and your depth and your strength and resources is very strong, and it was super helpful.
Great, thank you. Aaron, what would your words to a hospital CEO be if you knew they were considering conversion? What would you tell them?
Yeah, I think the number one thing is just to build on what's already been said, but a decision with no lasting consequences. So the decision to pursue technical assistance and make an evaluation does not lock you into making a change. So that's the type of decision as an organization, as I told my board, this is a decision that should be easy for us to make, because there's no out-of-pocket cost to the hospital to take a look at this model. So I would encourage, if your census is below 4 patients a day, if there's any concern about cash flow and maintaining your days cash on hand, you should be taking a look at it, because the reality is that evaluation process is going to take a number of months. And then we all know that the conversion process takes another number of months. And so if you get yourself backed in a corner financially before you start even looking at what your options are, now those conversations with the community can't be, here's an option we have, should we do this or not? It's now, I'm sorry, this is the route we're going, take it. And that becomes a much different conversation with the community. So I think as you can engage them early and make that decision before you're in a corner, it's a positive thing for everybody.
So before I turn it back to Angie and Anna, I just want to sincerely thank you, the 3 of you, for taking the time to just have this conversation with us today. I know folks across the country are looking to learn from all of you. While we count it a privilege to be in this space to provide you the TA, really you folks are on the front edge or the front line, informing all of us. So just thank you for your willingness to go first, and not only go first, but share your knowledge with all of us and the rest of the country. So again, thank you so much for taking the time to be here. And with that, I will turn it back to Angie and Anna. I do think we had a couple questions in the QA. If other folks have questions, please do drop them in the QA and we can spend a few moments answering your questions. So Angie?
I'm gonna read the questions here for you, and this is a question that I'm sure Janice and I could answer, but with your expertise here, I'm gonna open it up to you all. The question is from David, and his question is on the 24-hour requirement. Is it a hard cap where no patient can stay more than 24 hours, or is it an average length of stay where a short visit could offset a patient staying longer than 24 hours?
It is a number on average at the end of the year. You may have somebody that's there 10 days. You may have somebody that's there 10 hours, 20 minutes. As long as it's 23.59999 hours or less at the end of the year, you meet the requirements.
Yep,
Thank
and
you
I
both.
would just add from my perspective, so our average length of stay for the first 5 months as an REH has been 5 hours and 15 minutes. So yeah, we obviously have, and we have had patients that have stayed longer under observation. I think our average length of stay is like 32 hours. So a lot of flexibility there from that perspective.
All right, thank you both. The next question is, how are payers treating you?
Well, that's a loaded question. From my perspective, I haven't seen a difference. But anytime you make a change where reimbursement gets a little better, they'll figure a way to come back through that favored nations clause or something and say, we need to talk about that Blue Cross contract or that United contract. But I haven't seen any changes yet from my side.
I would echo that. At this point in time, Medicaid reimbursement, we're getting the same. I mean, we were a PPS hospital before, so we're getting the same PPS fee schedule rates on Medicaid. And obviously the Medicare, except for your labs and a few other carve outs, everything's plus 5%. So we are seeing that plus 5% on our observation patients. We're seeing that on our outpatient procedures. So that's a positive. And then most of our commercial contracts, I reached out to them, let them know I'm converting to an REH. I sent them a copy of our approval letter, but they said, your contract's set up at the tax ID level. Your tax ID didn't change. We're not going to change anything with how we're paying you. So even when we did the financial modeling, that made things easier.
Thank you both. I don't see any other questions in the Q&A, so I'll hand it back over to Angie. Thank you.
Thank you, Anna. Okay, we'll get rid of that beautiful beachside fire and move back into just our closing here. So just a couple of things. As I mentioned earlier, these slides will be made available to you, and included in that are these resources and links. We just kind of consolidated a few things that we thought you might be interested in exploring further here on this slide. Again, just a reminder that you can find all of this information as well as the recording to this webinar on our website within a week after the event. And if you're not already following us on social media, I highly encourage you to do so. We routinely post information that's not only relevant to rural communities in general, but more specifically to the REH hospitals. You'll see our website here, and you're welcome to reach out to us at any time if you have any questions. I'm going to be following up with a survey link via email shortly after the webinar is over. We do encourage you to participate in that survey, as we truly value your feedback on how we can continue to serve you and answer questions you might have in the future. And I really just want to extend a huge thank you to our CEOs for their time today. We know that your time is valuable, and we just love that you are able and willing to share your experience. And thank you to Janice and Anna for continued work in the rural health space and sharing your expertise with us today too. And then thank you to everyone for joining our webinar this afternoon. We look forward to seeing and hearing from all of you as you go through this journey in exploring the Rural Emergency Hospital as an option for your organization. Have a great afternoon, everyone.